Okay, I think I'd like to get started. Welcome everyone, and thanks so much for joining today's webinar. We are so excited to launch our new liver disease special interest group with their webinar, Helping Patients with Advanced Liver Disease and Their Caregivers Live Better. We have a great panel today with Doctors Arpan Patel, Anne Walling, Nneka Ufere, and Christopher Woodrell, and Lissi Hansen as well. Just a reminder that attendees are muted and the camera cannot be turned on. And representing today's the PCRC Executive Committee is Dr. Christine Ritchie. So I'd like to turn it over to Dr. Ritchie and have her formally introduce our speakers.
Great. Greetings, everybody. We're so glad you're here with us today to launch our liver disease SIG. And we have an incredible group of guest speakers that will be joining us today to sort of whet your appetite around this important area. We'll start with Dr. Lissi Hansen, who is the May E. Rawlinson Distinguished Professor at the School of Nursing at Oregon Health Science University. She's faculty scholar of the Palliative Care Education and Practice Program and Harvard Medical School Fellow for the Center for Ethics in Healthcare. Dr. Arpan Patel is assistant professor at the David Geffen School of Medicine at UCLA and a staff hepatologist at the West LA VA Medical Center, core investigator at the VA Center for Study of Healthcare Innovation, Implementation, and Policy. Dr. Nneka Ufere is a transplant hepatologist in the Division of Gastroenterology in the Department of Medicine at Massachusetts General Hospital and Harvard Medical School. Dr. Anne Walling is associate professor in residence at the Division of General Internal Medicine and Health Services Research, also at UCLA, assistant medical director of advanced care planning and services, the UCLA Health System, and also a palliative care physician at the West LA VA. And Dr. Christopher Woodrell, who's assistant professor at the Icahn School of Medicine at Mount Sinai, a staff physician at the James Peter VA Medical Center in the Bronx. So you can see we have an amazing group of speakers today, and we are so looking forward to hearing from them. We'll turn it over to our speakers to kick us off.
Thank you so much. So my name is Dr. Patel, as Dr. Ritchie pointed out, and I just wanted to say that we're so excited for this opportunity to come together as a group of researchers, clinicians, and leaders invested in these patients, and wanted to give a special thank you to PCRC and especially the National Institute of Nursing Research for providing this platform. As was mentioned, we have a presentation plan called Helping Patients with Advanced Liver Disease and Caregivers Live Better. And we hope this would kick off this collaboration and provide us a lot of important pearls to consider as we move towards research in this space. I think we all recognize the power of individual stories and being able to tell the context of what our patients are going through. So I wanted to share this story that of a patient that I took care of during training. So this is a 44-year-old gentleman who was having one of the worst summers of his life. He had multiple admissions for a recent diagnosis of alcohol-associated hepatitis and cirrhosis. And he had multiple admissions for many different complaints, which ranged from distension of his abdomen with fluid to fatigue, nausea, and confusion. He was diagnosed with several different complications of liver disease that we have come to know called ascites, which is the filling of fluid in the abdomen, encephalopathy, which is associated with confusion and makes it difficult to take many medications, as well as renal failure requiring hemodialysis because his liver was providing very little fluid to the kidneys and was causing the kidneys to fail as well. During one of his admissions, he was actually noted to have what's called a MELD sodium score of 40. This is a marker of the severity of liver disease. And during that admission at our academic medical center, he was considered for transplant, but ultimately turned down because he had high-risk alcohol use disorder. When he was seeing me as a patient, I noted that though his condition had stabilized, he still had significant needs. He was unable to take his medications without feeling confused. He had problems with mobility, and he had very limited social support. He was living with his sister, but she was also raising a child, and we had to configure through a list of all of these medications to take, along with navigating through his difficult path socially. But across a few months, we were able to make some progress. We found that due to his needs, we decided that he should be admitted to a skilled nursing facility, and he took that in stride, and that helped him stabilize his liver disease while he took his meds. We also explored his alcohol use disorder and understood that some of his triggers were related to a recently failed marriage, and he had underlying depression and anxiety that were undertreated and needed to be addressed as well. After several months of him being abstinent from alcohol, he was able to improve his liver function, was actually able to come off hemodialysis and go down on several of his medications. His MELD sodium score went down from 40 to 28, indicating and recognizing this change. He told me several times that he felt like a new man, and we had many positive visits to reinforce kind of all the progress that he'd been making over the course of several months. Unfortunately, after the turn of the new year, things took a different picture. I received a call that he was found unresponsive at his nursing facility that he was still at and was admitted to a local hospital. And he sustained a complication that's common for patients with liver disease and ascites, which is that he had an infection in his abdominal fluid. During this admission, which was at another hospital, they continued to talk about the idea of liver transplant because his MELD sodium score went back up to 38, meaning that he was someone who would need a transplant, but unfortunately he was too sick. Over the course of several days, despite receiving high intensity care and antibiotics, he did not improve. And he received many life-sustaining treatments, such as mechanical ventilation and vasopressors. After several rocky days, myself, his sister, and his family, as well as the treating team, decided that continuing aggressive care wouldn't get him the life that he wanted back. And so they decided to withdraw this after 6 days. Unfortunately, this is a really similar case I deal with for many of my patients. And I think there are several themes that have emerged from it I think are important to consider when thinking about this population. They have a significant unpredictable illness trajectory and with a rocky course. And as you can mention, several times, despite being towards the end of life, there were opportunities for cure that were presented, but not always clearly in line for the patient, or it wasn't clear that it was an option for the patient at all times. In addition, for this illness trajectory that's very unpredictable, patients have high rates of physical disability. My patient had needed to go to a nursing home because he was unable to take care of himself despite being 44 years of age. And there were so many different psychosocial needs that played into his difficulty in coping with this illness, not just depression, anxiety, but addiction. And so I think that this case for me presented a lot of what I find challenging in dealing with these patients, and I think gave a glimpse of the types of lives that they lead. So today I wanted to expand on this discussion and not just think about an individual patient, but what are the actual needs of patients in this whole population of advanced liver disease? And I wanted to also describe an agenda that we have as part of the PCRC liver disease SIG and expanding the area of research for this population. Following our small set of slides, we have a Q&A session with a really wonderful expert panel, which represent leaders in our group, including Dr. Ufere, Dr. Woodrell, and Dr. Hansen. I wanted to provide a few introduction slides to liver disease, since I think it's important to provide a pretty broad context to it. And many individuals here may not be as familiar with the population. So what I like to think of is these diseases that represent cirrhosis and decompensated cirrhosis often present the final stage for many different diseases affecting the liver. Liver disease affects 4.9 million adults in the United States, and the major causes are infections like hepatitis B and C. But what are becoming more common are alcohol-associated liver disease and non-alcohol associated fatty liver disease, which is associated with metabolic syndrome and obesity. Once patients have a significant amount of injury to the liver from these chronic liver conditions, they can develop cirrhosis, which is a syndrome associated with scarring of the liver as a consequence of this injury. And that represents and affects a smaller fraction of these patients, about 630,000 adults in the United States. The serious illnesses that we're talking about that when we refer to advanced liver disease are what's called decompensated cirrhosis and hepatocellular carcinoma. Decompensated cirrhosis means cirrhosis in which the liver function has been lost. And these cause what's called complications of portal hypertension. And these cause plumbing issues in the liver, which can lead to bleeding, can lead to confusion, as we had in our patient, fluid in the abdomen, as well as jaundice. Another important consequence of cirrhosis is liver cancer or hepatocellular carcinoma, which is a growing cause of cancer and cancer-related morbidity, as we're finding, and we'll discuss in another slide. And this actually affects, these conditions together affect over a half of the patients that have cirrhosis, which is a large percent of the population. What's really concerning is that these conditions are increasing significantly. And so I wanted to present some of this epidemiology and context. In the United States, advanced liver disease is the fourth leading cause of death for individuals between the ages of 45 and 64. And for many people, that can be the most functional years of their life. What's even more concerning is that liver disease has increased by 65%. Deaths have increased by 65% over the last 2 decades. And this has been attributed to increasing patterns of alcohol use, as well as increasing obesity in this country, contributing to alcohol-associated liver disease and non-alcohol-associated fatty liver disease. Even more surprising is the fact that liver cancer is now the fastest growing cause of cancer-related death in the United States. And despite all of these really concerning trends, these patients still continue to have very dismal prognoses. Patients with decompensated cirrhosis roughly live only half of them live up to 2 years after being diagnosed. For patients with liver cancer, that number is 30% at 5 years. And for the patients that actually require a liver transplant as an option, or can use liver transplant as an option, only 8% of them receive this curative treatment after 3 years of being diagnosed. So I hope this kind of presents a little bit of context to really the struggle that our patients are dealing with and the enormous walls they're faced against just in dealing with their serious illness. And really the enormous wall that we're facing as a healthcare system to deal with the worrisome trends of this population. So I wanted to pass over the slides to Dr. Walling, who will be giving us a little bit more of the research in the palliative care needs of this population.
Thank you, Dr. Patel. So over the last 5 years, there really has been an increase in research in palliative hepatology, and I'll review some of what we know. And I think it'll make it clear of why it is so important to do more research in this area. So this slide shows symptom burden for patients with end-stage liver disease compared to other serious illnesses. The data here from end-stage liver disease is from a systematic review through 2018, looked at 35 studies that looked at symptom prevalence in this population. And some key points here is that there's a high burden of symptoms. And interestingly, many of these symptoms may not be directly related to portal hypertension. And so next slide. And this slide summarizes some of the key data from a more recent study, which led by Dr. Hansen, who's one of our leadership, part of our leadership team for this SIG. And she'll be a part of our panel discussion today as well. So this study looked at 146 patients with child CTP B and C, and the patients in this population had an average MELD of 19. So here you can see that the symptom prevalence is quite high. And interestingly, of the 5 most common symptoms in this population, 4 of them were also rated the most distressing symptoms by patients. Another key thing here to point out is that Dr. Hansen also looked at treatment for these symptoms with medications, and you can see very low rates of treatment with these for some of these things. So for example, difficulty sleeping, only 16% of patients were on medication. And for only 23 of patients with depression were on antidepressants. And this might reflect either unrecognized symptoms or concerns for treating patients with impaired hepatic metabolism. And so again, this is an area that really requires more work and more research. Next slide. So another key study led by Dr. Hansen here, she surveyed 132 dyads of patients and caregivers, and anyone who has tried to enroll dyads knows how hard this work can be. So in these patients were sampled from hepatology clinics with a MELD, and the patients had a MELD of 15 or more. So these results show SF36 scores. So just to put this into context, the average score for an average person in the population is 50. So these are very low SF36 scores, not just for patients, but caregivers. So it's below what you would expect for in the average population. And a couple key things to point out here are patients with ascites or refractory ascites were more likely to had lower scores, both patients and caregivers, for physical quality of life, and hepatic encephalopathy was associated with lower physical quality of life in patients. Next slide. So we know that patients with the end-stage liver disease have an advanced liver disease have a high level of symptom burden. But what's also interesting is that there's low rates of palliative care utilization in this population. So this is a study by Dr. Patel. He looked at data for this study from the national inpatient sample. This is data between 2019 and 2013. What's interesting here is that even among patients with advanced liver disease who die in the hospital, only 30% of them were receiving palliative care. Next slide. And this study by Dr. Ufere, also one of our leadership team members, has done work to try to get at what are the barriers to palliative care utilization from the provider's perspective. So this study represents a survey that was done among hepatologists and gastroenterologists from the AASLD membership directory. It had a very good response rate for this type of study. And so there's 396 respondents. And common barriers that she found here included perceptions about palliative care from providers, unrealistic expectations about prognosis, and competing demands for time with the thought that the symptom and communication symptom management communication can take quite a bit of time. So, and a key factor here that I want to focus on a little bit is this, which is unique to this population, is that this population has the potential for curative liver transplant, which Dr. Patel also spoke about. So this is a unique for this population and an area of where there's a lot of research opportunities. Next slide. And this is a recent study by Dr. Patel that was published in JAMA Internal Medicine. So in this study, he looked at, he did qualitative work. So there were 88 qualitative interviews in this study, 42 from patients and 46 from providers. And these participants were sampled from high volume transplant centers in California. And these are some key themes that emerge from this work about deficits in particularly in advanced care planning and information and care planning at liver transplant centers. So here you can see some of the key findings are that most patients' consideration of values, goals, and preferences occurred outside of outpatient visits. So it happened at times of crisis rather than in advance. There was also found optimistic attitudes from transplant teams that this hindered discussions about dying. And as we've seen before, these are that patients do know that do have questions about these things. Clinicians primarily discuss death as a strategy to encourage behavior change, and transplant teams avoided discussing non-aggressive treatment options. And lastly, a key theme here was that surrogate decision makers were often unprepared for end-of-life decision making. So this gives a brief overview of some of the key unmet needs for palliative care in this population. I'll hand the slides back over to Dr. Patel.
Thanks, Dr. Walling. So I think even just from the few minutes of our presentation so far, you can see that we've come a long way when thinking about the palliative care needs of this population. And I wanted to highlight the fact that many of us actually in this leadership team have been organized in a group called PEARL since 2017, or the Palliative Care Education Advocacy and Research in Liver Disease Work Group. And, across 4 years, having monthly meetings together with this wonderful community, which I really consider a big professional joy of mine. We've had a number of important milestones that I wanted to share, which have led us towards this path of joining the PCRC Liver Disease Special Interest Group. The first is that we've been very academically productive. So, in our group of 8 researchers, we've had 35 original research articles. In addition to those, we've had 25 review articles in many high impact publications and journals. And we've also authored 4 book chapters. So I think, in thinking about how we can expand the research in this field, we've at least cultivated a group of people who are productive and who see the value in research and really expanding care to our patients. I think an important thing with any research is understanding the source of funding and how we can communicate with stakeholders in funding to make sure that we're producing research that's in line with their frameworks and expanding research from many different angles. I'm so proud that so many individuals in our group have really been successful with funding efforts. I wanted to highlight a few. First, Dr. Hansen, who many of our former slides had highlighted, had received funding from the National Institute of Nursing Research, an R01 grant, which has produced many of the different manuscripts that we've laid out. Manisha Verma and Dr. Victor Navarro are also part of a multi-center randomized control trial that's funded by PCORI, which has been ongoing and going to be finishing in a few years. In addition to these very large grants, we've also been able to secure funding for many of our early career investigators. Dr. Woodrell has been able to receive funding from the National Institute of Health and National Institute of Aging, as well as the ACS and some career development awards, as well as Dr. Ufere has received funding from the ASLD, which is one of the liver disease professional societies, receiving a very prestigious career development award. Myself and Dr. Walling have also been part of a pilot study that was funded by the VA HSR&D, or Health Services Research Corps. And so I think the fact that we're starting with so many different and diverse elements of funding, including NINR, is really providing us an important framework for building a community of researchers. I think a really important part of research is making sure that our stakeholders are not only just funders, but also the individuals who are going to be implementing practice change. And one unique change that has happened in our field is how many clinicians and patients have been really responding to the increase in palliative care research. I wanted to highlight a few important turning points we've had in being able to do this. So Dr. Tanda and Dr. Walling have actually participated in the American Gastroenterologic Association guidance on palliative care for patients with cirrhosis, which is the first of its kind for any GI professional society. And it outlined many different best practice statements based on our prior research, which I think is a crucial and groundbreaking shift. We've also had a number of different webinars for the ASLD, which is again the major professional society for liver disease in the United States. They've been actually growing in depth and focus. A few years ago, we had one on what palliative care is from Dr. Rakowski and Dr. Hansen. We had 2 recent ones this summer that have focused on advanced care planning at liver transplant centers, as well as one in which we introduced tips and pearls about end-of-life communication for patients in different diverse groups. That was led by Drs. Ufere and Dr. Woodrell. What's really exciting, which we're also hoping is going to be another shift in clinical care, is the fact that we're in production for a guidance from the ASLD on palliative care as well. So what's been unique about this area of research is that we've really been able to engage and move and shape the care that we're trying to shape quickly. And the last thing I wanted to highlight is the fact that we had a recent publication in Hepatology Communications, which was a modified scoping review in which our goal was to actually shape the research priorities for palliative care research in this population. what we did is we actually found really key areas to focus on that were based on the National Consensus Project guidelines for palliative care, different domains of palliative care research that needed more exploratory work, and others that needed more implementation work. And we actually settled on four key areas of research and described in the publication different studies that we would undertake to explore these gaps in research. So this has provided us a really important and enormous framework for us to build further. So what are the goals of our special interest group? We have three that we wanted to highlight, which I think are important for any collaborative group. The first is that we want to engage researchers, people who are interested in developing high quality research and develop a collaborative community around them. As you can tell, this is our group that has done a lot of this research has been productive, but there are several individuals outside of our group who've also been productive, and we want to be able to share the science with them as well as create new science. We also find it's really important to engage the funders to develop high impact research, including not only just the National Institute of Nursing Research, which has funded so much of our work already, but as well as PCORI and PCRC, the VA, and other funders. And the last thing is that we want to continue to engage stakeholders to promote practice change, not just professional societies that are listed below, but patient advocacy groups that can also benefit from this research. So these are our three main pillars that we hope to stand by when developing our liver disease SIG. In terms of strategies on how to build a research community, we've had some thoughts about having quarterly meetings that are structured that will be able to allow early to senior investigators to participate in our activities. Some of the things that we have planned are a journal club where we highlight liver disease research and try to troubleshoot and get at the root at what some of the benefits and challenges were for exploring a few questions. We think this is an important way to build an academic credence for this type of community and this type of research. We also want to inspire people to present some of their works in progress. And we recognize that there's a significant gap in researchers in this space, and getting high quality feedback for work that we're developing is not only important, but it's also very efficient, and it can also lead the direction of the field in important ways. So we do find that this could be important to not just early career investigators, but also senior investigators. And lastly, we want to be able to have a framework for developing multi-institutional projects. We see these, many of us are clinicians that see these patients in and out. Many of us are researchers that have cohorts of these patients. There's no reason why we can't look at this as an opportunity to collaborate and develop high impact research and develop collaborative grant opportunities as well. And so these are just a taste of the different ideas that we have that we believe the SIG can represent and can elevate. So wanted to give a good amount of time for us to be able to engage the rest of our leadership team and really ask some questions that I think can illuminate some of the different experiences and challenges we've all been having with this population, with this research. So with that, I wanted to open it up for questions. And so we'll look through the chat and as well as ask a few questions of our leadership team. So I don't see any questions yet. I did want to pose one question for us just to get started. Wanted to go around and just ask the question for all of us, if you can say a little bit about what got you interested in advanced liver disease and palliative care research, and what influenced your work, or who influenced your work. And we can get started with Dr. Hansen.
So thank you for that question. I have been fortunate to be funded by NINR since 2007 to focus on people with liver disease. And I have a lot of clinical experience. I have worked in an intensive care unit. And what I really found unique with liver disease patients was their complex physiology, their multiple symptoms, and also their often so strained relationship to their families. And more so even today, both families and patients are very stigmatized. And also some of the services provided for people with end-stage liver disease are not really tailored to their specific needs. So another thing I just want to add is that people who are stigmatized, in my experience with working with this population for so long, is that they don't feel that they have anything to offer. And when we really ask them, we could use their experience, they open up and have been very forthcoming in, at least in my research and also in my recruitment efforts. So thank you.
I think that the element you present about stigma is such a huge thing that doesn't get talked about a lot in our clinical and research care. So that's a really important perspective to bring. Dr. Woodrell.
Thanks so much. You know, my path to this, developing these interests in my research has come from being sort of roundabout. I started off before I had even discovered palliative care in medical school, working in basic science laboratories on liver disease projects, and was sort of going along thinking I would become a gastroenterologist. But once I discovered palliative care and realized this is how I want to practice, these are the people I want to practice with, and this is how I want to approach helping people live better with serious illness, there was, it took me a while for the light bulb to go on and realize that this would be a great sort of mix of my interests. And I think I absolutely second what Lissi said is in terms of what stands out to me is in this population of people facing liver disease is the stigmatization. I remember very early on, before Lissi and I had met, I read one of her papers and there was a quote in there, somebody saying, there were no parades for us, there's no ribbons, there's no pins. And it just, that combined with the uniquely challenging course that many people face made this something that I wanted to look deeper into, helping people live better with this.
That resonates a lot with me, just the idea that, it's an unexplored space. There's few of us who are strong and have been developing this community, but I think it is in many cases a struggle sometimes to do the research, but it's nice that we've sort of found a community of people to really deal with this population seriously. So thank you for that. I did want to ask Dr. Ufere if she could also share some thoughts.
Can I interrupt for just 1 second just to read some comments from
sure.
the chat?
Yeah, sure.
So let me see, make sure I can see the right. So Grace Cullen comments excellent points about the strained relationships resulting to a lack of support system. There is a lot of self-blame due to previous choices in lifestyle that may have led to the disease, so there may be less inclination to endorse symptoms and seek management. And another comment by Simona Jacob, I apologize if I didn't say that correctly. Such a great idea to create this forum. Looking forward to working with everyone. So I think I just wanted to comment. It's so nice that there's so many people here attending, and so I just wanted to get everyone to ask their questions in the chat, and I'll go back to Dr. Patel.
Yeah, absolutely. I'd love to hear a little bit more from Dr. Ufere about what got her interested in this field too.
Thanks, Dr. Patel and Dr. Walling. That was a beautiful presentation, and it really captured so much of our experience as hepatologists with our patients and the huge areas of need. I think that the story that Arpan shared about the patient that he took care of is an experience that all of us as hepatologists feel and see. And when I look at what my personal statement was for fellowship, I had been planning to do translational research on viral hepatitis, but it was really those recurring patient stories during my first year that drew me to this area, because I really struggled that year with how much our patients were suffering and how little at the time was available to really improve their symptoms and improve their quality of life. So really it was clinical experiences that made me completely shift what I thought I wanted to do professionally towards this area.
Thank you. And I know we have a lot more activity in the chat. I actually would love to hear a little bit from Dr. Walling as to what got her interested in this field too.
That's so I can say that there's a lot of reasons I think I got interested in this field. And it's really interesting because I work at both a transplant center as well as a VA center that's not a transplant center. And so I've seen how how there can be different solutions and different structural issues. And so I think it's like really great to really be able to kind of try to solve some. So I'll just give a particular example. So when I started as a palliative care attending, I would see that I would often see patients at the end of life, and they, may not have been considered for transplant due to some of the issues that were brought up by our other experts here on the panel. And so one of the things that I started to do is kind of figure out why are these patients not being considered for transplant. So identifying patients based on MELD score, for example, when they're admitted to the hospital, and meeting with them and understanding what their needs are, and just trying to get the needs met up front, like earlier, so that I was confident that patients could receive concurrent palliative care, could also be evaluated for transplant if that was appropriate, could also have caregiver needs met, and really just sort of meeting the patient where they're at. As it turns out that a lot of patients didn't even realize that they had a serious illness. They knew they had a problem with their liver, but they didn't necessarily recognize, they didn't have that prognostic awareness. They didn't have that one moment. And so really, I just became very passionate about trying to figure out what the issues were upstream so that we could do a better job for our veterans and for patients outside the VA as well.
And that resonates so much with me as well. As how I got interested was also surrounding end-of-life care for these patients. And I've trained at like 4 transplant centers and was recognizing this constant cycle of patients who actually in many cases were well connected with the transplant center, but as soon as they didn't have the opportunity to get a transplant, I sort of felt that not just the transplant center, but everyone just seemed to abandon the patients and their needs. And I was trying to understand why structurally this happens and why there isn't an interest in modifying and capturing the experiences of them. Because I sort of viewed this field of hepatology, and I still view this field of hepatology as some of the most inventive and interesting and incredible people I know. So I sort of understood that I think palliative care and delivering palliative care is an identity of most hepatologists. They may not recognize it, and systems don't always value it. But I think it's something that we've now led our community in making sure that it is part of our care. And I think it's now our way of sharing that implementation and creating systems of implementation that will lead it to the next level. So that's how I got interested in it. I
want to add one thing that I think is so exciting about this collaboration is that it's, collaboration between hepatologists and palliative care clinicians. I think that a multidisciplinary interprofessional group together can really change the way that we think about caring for patients and really make real true differences.
Absolutely. It looks like we have a few questions in the Q&A. So one is from Dr. Lisa Dang. So she asks, what opportunities do you see in drawing from existing work in other patient populations with chronic disease and advancing palliative care research for patients with advanced liver disease? I'd love to actually get Dr. Hansen's thoughts. Open it up to anyone, but I know that Dr. Hansen's been doing a lot of work with palliative care and other chronic illnesses.
Thank you for a great question. I do believe that patients with end-stage liver disease are very unique, but one thing I focus on in my research is using valid and reliable measures that hopefully can be translated with the findings and compared to other chronic illnesses like heart failure and kidney failure. So I think there's room for both. Use some of the things from other diseases and see if it works for the patient population with patient with liver disease in particular. But also there are unique findings, I think, that needs to be discovered for a patient with end-stage liver disease. So I welcome both approaches, the focus on liver disease specifically, and the focus from other chronic illnesses and applied to patients with end-stage liver disease. Thank you.
And along the lines, I feel like there is this constant struggle of comparing our population to those of other seriously ill populations and making sure our research is distinctly different. I wanted to open it up to everyone is to talk about, what are some of the challenges you find in researching our population and some of the things methodologically or just pragmatically that you found are difficult?
I think something that's particularly difficult, that's probably going to require larger societal change and thinking more about the stigma of liver disease is that, I think Annie or Dr. Walling made this point that our patients really don't have as great a sense of their prognosis. And I'm someone who lives in a cancer, a palliative care research group that really focuses on patients with cancer. My mentor is an oncologist, and I oftentimes use the example that the experience of my patients with liver disease is so distinctly different from the experience of a patient with cancer once they enter into the healthcare system. So if you have two 50-year-old men with jaundice who are admitted to the emergency room, and one is found to have pancreatic cancer and the other is found to have decompensated cirrhosis, the amount of support that they get within the hospital at the time of discharge and once they leave the hospital, and the supports that they can look for online or even through their families or through like societal support are so distinctly different. And so, I sort of use that example to really show how much our patients are up against in terms of the limited amount of support that they get. And as we're thinking about how to build interventions to support them, we also have to start thinking a lot more upfront about that larger societal issue of our patients with liver disease just not receiving the amount of empathy that a patient with cancer may receive.
I just want to build on what you are saying, Nneka. I actually had a patient who had primary breast cancer and talked about the pink hat, the coffee, the get together when she came to the clinic, the treatment sitting in a huge lounge chairs compared to when she was diagnosed with liver cancer and was assumed that she had been an alcoholic, which she wasn't. And the treatments was inside for the taste treatments in a locked room, the waiting room, no windows, no coffee, nothing. So I just really want to support what you just said. So thank you.
I also want to support it. I think it's such a key important area, and actually it relates to a question that just came up in the chat from Paul Galchut. Thank you for creating this SIG. I also appreciate your comprehensive sense of addressing the domains within the National Consensus Guidelines. Will you also please speak to your sense of addressing religious, spiritual, and existential domains?
So
domain 5 content, yeah.
I'd love to get Dr. Woodrell's perspective on that.
Yeah.
I was just going to comment. Thank you for that question. We, as part of that publication, as Dr. Patel mentioned, it was a sort of modified scoping review. And I think Dr. Hansen and I did that search. And that was by far the domain with the least amount of information that we were able to find. It was almost nothing. So that is an important, I think, gap to shine a light on in terms of existing work. thinking about it for something we're writing recently, it was all extrapolation from other general seriously ill populations.
For me, like it's not shocking that there's not a lot of research in it, just given for many of the reasons we've mentioned about how difficult it is to do research and approach, but it's something I see all the time, in patients who have struggling with addiction or struggling with navigating through all of these different, vicissitudes in their life. Like religion and spirituality is such a binding force that when sometimes you ask patients about their lives, I get so many of those themes. So it's so surprising that there's very little in there. And I think that's a big opportunity to explore when thinking about treating our patients in a cultural context that they respect.
I just want to add.
Go ahead, Dr.
Coming up, I won't say anything else, but religion and spiritualities has actually been part of the R01 that has been longitudinal with 5 data points. And it's part of the analysis related to the patient's symptoms over a year. And I won't say anything else. It's in process. So hopefully the paper will be submitted soon.
And I think to everyone's prior points, I appreciate the question from Mr. Galchet, but for our patients with advanced liver disease, I think that we do have to really have an increasing investment in this domain of assessing their religious, spiritual, and existential needs, particularly because our patients struggle so much with how to deal with uncertainty. When our patients develop new liver disease complications, they can't predict when they'll happen. They're oftentimes acutely ill, sometimes critically ill, and supporting them and their caregivers in how to deal with uncertainty, how to cope with the disease process that is in many ways incredibly cruel, and how to find other sources of support to really improve their overall well-being and coping is, I think, going to be really critically important to the unique needs of this population. So this is a much, much, much needed area of investment.
Yeah, I just want to highlight one thing that you said about uncertainty. This is something I didn't comment on in the slide of Dr. Hansen when I was presenting Dr. Hansen's data, but uncertainty was associated with decreased quality of life for caregivers as well. So I think that there's so much here, and so it's so much work to be done.
There's another question I wanted to highlight coming from Dr. Crystal Brown. She says, as we begin to expand palliative care for patients with advanced liver disease, do the panelists think we need to think about managing transplant eligible versus transplant ineligible differently? This can be such a fluid construct. I believe it overlaps significantly and patients can be considered similarly, but there seems to be strong feelings that it should be approached differently. I know we all have interesting things to say about this, but I'll let anyone take it away first. Go ahead, Dr. Woodrell.
That is such a great question. And it also speaks to a comment that somebody made up thread, which was about wondering how to help people who were pre-transplant. And that comment also resonated with me because of that label pre-transplant, which a lot of centers use pre and post as a sort of label for people in relation to transplant. And I think, so whether it's eligible or pre, whatever you call it, I think just that term highlights the uncertainty piece, because really we don't know that someone's a pre-transplant until the transplant occurs, and then they were pre-transplant. But other than that, like, nobody can say, and people sit with that, or they don't sit with it, or no one talks to them about the uncertainty. And then, but either way, I think it's a really something that perhaps is unique to this population, is that true uncertainty of whether this curative intervention will be done for them. Whether I struggle with the idea of really creating separate paths. I think that would be potentially the wrong direction, and I would advocate to lean into the uncertainty instead?
Yeah, and I think a lot of the division is artificial and has probably been created by structural issues. The fact that transplant patients are managed at transplant centers, or those that are peri-transplant are, and that these patients just receive different care or care at different facilities. But you can have many needs in palliative care, whether you are transplant eligible or not. I think there are different populations with regards to prognosis and opportunities for cure. And it's like what's been mentioned from all of us, that uncertainty and understanding the uncertainty and whether you are someone who can get a transplant or not is one piece. I think there's so many domains outside of that that can be shared between the pre-transplant and transplant population.
Yeah, I'll second that. I am a fan of an integrated model for patient-centered advanced liver disease care that sort of considers all of these things as part of a nuanced approach to providing high-quality patient-centered care. And that I think that depending on the population, there may be different issues with access, and just making sure that, that patients get opportunities and access to all the high quality processes, including access to hepatologists when appropriate, including access to transplant evaluation when appropriate, as well as palliative care access and all of those pieces as well.
I wanted to see if you had another question I wanted to pose. I know we have less time left. Was anything you're specifically looking forward to with regards to working with this collaboration? And I'll leave that as an open question for the rest of us.
I'm just so excited at all the interest in this area, and individuals from hepatologists to palliative care clinicians to general medicine clinicians who, when living in a space where you feel like your patients are not getting the care that they deserve, it feels great to have people interested and invested in this population. So we're excited to build the team.
Somebody asked a moment ago also what we could learn from other sort of niches of palliative care research, and I think one of the things we can learn from others is the importance of bridge building, and that's what I'm looking forward to here. I would also, I think I have been really heartened to see from my vantage as a palliative care physician, the amount of interest from the specialty hepatology world in this. I mean, having the PCRC trial, the Pal Liver trial with 18 sites that's ongoing, that is, literally 100 hepatologists coming together for that is really something. And so all of the shared interests and energy out there, I think this is a great opportunity to harness that.
I think that there's so much room to have these discussions in a research context and to also build these bridges through research. We're going to be holding at least quarterly meetings, like I mentioned, trying to do journal clubs, trying to do works in progress. And I think these discussions of building bridges are natural. It naturally follows with some of those activities. And for all the people who are interested, individuals who are interested in joining the special interest group, we're going to try to be active to spur some of these discussions, because I think a lot of these are practical challenges we deal with too in building bridges. And so we're really looking forward to the opportunity of engaging people in the special interest group towards some of these practical things we deal with performing research. Any other final thoughts?
I'll just say that it really is an amazing group, and so we're excited to work with people who are excited and have similar passions to make our patients' lives better.
And I ditto as maybe a little the odd dog, but this is just absolutely wonderful. And I am so delighted and so honored and so pleased. And thank you to the people who also have attended. The more, the merrier. So this is great. Thank you.
We wanted to give a special thanks to everyone who tuned in today, because I think your energy and your enthusiasm is what are part of the reason that we're interested in this space and it motivates us for what we do. We wanted to, of course, thank PCRC and the National Institute of Nursing Research for providing this opportunity for us to have these discussions and be able to move forward with our vision of palliative care research is growing as a collaborative and international community. So we thank you so much for this. And we will definitely look forward to hearing any of your questions that you have for us afterwards too.
Thank you so much, Dr. Patel. I believe we have one more final slide if there's no other questions. Thank you so much for joining today and for an excellent discussion with such a great panel. Please do complete evaluation that's going to be sent out by email about how today's webinar went. And in that email, you'll also see instructions on how to sign up for the special interest group. And I just want to remind everyone on the call that you must be a PCRC member to join a special interest group. So I can direct you to how to do that as well. Next month, we have Dr. Joanne Lewis, Catherine Hooper, Dr. David Currow, and Dr. Patricia Davidson to present on social capital, conceptual and methodological issues in palliative care research. So please retrieve that, see how to register on our website, and we hope to see you involved with the liver disease SIG. Thank you again so much to our leaders and all of the attendees who joined today. Take care.
Take care.